Yuan is from the National Cancer Hospital, and this topic today will be the angioedema application in case of the Yuan, please.
Good morning. Today I want to talk about angioedema application in transarterial chemoembolization. So angioedema is defined as a system that combines of angio unit and CT scanner. This system may be very complex or may be simple with just a mobile CR plus a CT scanner. The main purpose of all the system is to acquire high-resolution CT image during the interactions. So about 30 years ago, in the beginning of the intra-interior CO2 microbubble to diagnose small diseases during the intervention by ultrasound. And then later the continuity is invented and help interventionists to detect the lesion and its fidelatories and also monitor the emboli area after the intervention. And now with angioedema, we can simplify the procedure workflow and we can achieve superior imaging quality with a larger field of view. There are many techniques can be used in case with angioedema. Firstly, we can perform the CT during arterial photography. We select the superior mesenteric artery and then we pump the contrast into it. So after half a minute, the contrast can reach the portal vein near the mesenteric circulation, and then we can isolate the stream of portal vein on CT. So in CTIP, all the lesions that do not receive blood from portal vein like ACC, ICC, metastasis, or hemangioma will be very prominent. So we can easily spot the lesion. This is one of the most sensitive modalities in clinical imaging. The second thing is if you face hepatic arterial CT, when the catheter is located in the common hepatic artery, proper hepatic artery, or cerebral trunk. In the arterial phase, we can detect hypervascular lesion and thickened arteries. And in the delay phase, we can watch the drainage of lesions, so we can distinguish ATC from the other lesions. Lead test or FCD is the non-contrastive that is performed after the embolization, and the purpose is to evaluate the embolization zone and predict the response. So why should we use angioedema for test? There are many advantages. Firstly, angioedema can detect ACC accurately and easily. We see this clinical case. This 78-year-old man who has hepatitis B and he has 3 nodules on MRI. The largest lesion is about 42 millimeters and 2 small lesions do not have typical hemodynamic ACC on MRI. And most lesions is on the right. So is the patient suitable for test? The patient had 3 lesions and with the size between 3 to 6 centimeters. So based on the IPLC consensus, we can say the patient is suitable for test. So we test him with angioedema, but in the angioedema you can see the 3 lesions that already seen on MRI is very prominent and easy to see and typical for SCCs. But the problem here is there are 4 more nodules that do not appear in MRI. You can see the first, the second, the third, and the fourth, very typical for SCC, but there are nothing in MRI in the same location. So in fact, in the patient, we have 7 typical SCC tumors and bilobar lesions. So based on both FELC consensus and ECLC guidelines, the patient is switched from suitable to test to unsuitable for test. So after the first day, we switch the patient to TKI therapy. Many research show that angioedema and continuity during the intervention can detect diseases more accurately than conventional CT and MRI. Especially the CT AP may have test sensitivity is nearly 100%. And in this research, in Iwasawa, he said that nearly 30% lesion cannot be treated without CT scan findings. So angiosync can detect accurately the lesions that cannot be seen on conventional CT or MRI. So it proposed more suitable studies of patients. Another advantage of angiosync is that it can isolate and detect arterial and portal venous blood flow even in tiny nodules. We all know that ACC has multi-step carcinogenesis from cirrhotic nodule to the dysplastic nodule and then into ACC. And in this process, the portal vein flow is decreased while the arterial flow is increased. So we have the early enhancement and washout on imaging. But in early ACC, the change of blood flow may be very mild, and the flow of hepatic arterial and portal vein is missed on conventional CT and MRI, so it may be very hard to distinguish ACC from dysplastic or cirrhotic nodule in the MRI or CT. But with angiosync, we can observe separately the portal vein flow in CTIP and the arterial flow in the CTHF and the drainage of the lesions. Therefore, we can diagnose even the small and early ACC. So we have a true 51-year-old male with hepatitis E. He has normal AFP level and multiple nodule on MR. You can see a small nodule that's located in the segment 6. This lesion is hypointense on T2 and has early enhancement but no clearly washout and no restricted diffusion. And other lesions is hypointense on T2 and hyperintense on T1 and mild enhancement, no washout and no restricted diffusion. So on angiosync during the TACE procedure, you can see a small lesion in segment 6 has decreased portal flow in CTIP and increased arterial flow and has mild washout but no coronal enhancement. So the feature is typical for an early ACC. In the other nodules, there are no abnormal flow fusion in CTIP and CTHI, so they probably dysplastic and cirrhotic nodule. So we decide to perform ultraselective test with creatinine 10 for the small ACC, and the lesion has completely responded after treatment. In this patient, in the third case, we have two nodules. The first nodule is in the segment 5. That is a mildly hypovascular but no clearly washout, and the second nodule in the segment 8 is VSIR and hypovascular after contrast. On angiosync, you can see clearly the smaller nodules in a typical ACC with hypotension in CTIP, early enhancement, washout and coronal enhancement. And the interesting thing here is in the larger nodule, we can see a small portion that have typical features of ACC and is located in a larger nodule that had decreased on the portal flow and the arterial flow. So it's clearly an early ACC nodule in a dysplastic nodule, a nodule in nodule pattern. So we treat both the nodule with the selective test, and the CT show that the lesion has good lipiodome deposition on the lesion. Another advantage of angiosync is that we can find the feet arteries more accurately and easily. I want to show you the fourth case, the 65-year-old male patient, and he has a small ACC in the segment 8. He was treated with the IFA, but unfortunately the ablation zone is not reached a CT measure. So there are a small residual tumor in the CT image that was taken 2 months after the ablation. In this patient, it's hard to ablate this lesion again because we cannot detect the residual portion on the ultrasound. So we choose to perform this in this patient. On the angiosync, you can see the residual portion is very small, and and it's difficult to see and to find the feeder artery or the lesion on the X-ray image. But in the arterial phase of the CTHA, we can easily find the portion is has a supply arteries from the middle hepatic arteries. So then we can select it and we confirm it with CTA, and the VCT after the embolization also confirm that we treated the right target. This is a CT image after 2 weeks after the test. With the liquid deposition in the target lesion, we can perform the second ablation with the CT guide, and the lesion has complete response. This is the MRI image after the second IOA. Here is the fifth case. There are multiple SECs in a 66 male patient, 66-year-old male patient, and in this slide we can see clearly that there are multiple tumors with multiple feeders. But there are how many feeders exactly are there? And what should we go first? How to weigh the main feeders, or how to calculate the dose? It's very hard to make a plan on this patient based on the X-ray image only. So with angiography, we can easily diagnose all the tumor feeders, and this supplies. The main feeder is from the posterior segment artery, and there are 2 other feeders from RHA and LHH. So we can easily make a plan, we select all the feeders in order, and we embolize the tumor with that test. And the lesion had responded to one time. Another case, a young male patient with large ACC in the segment 5. The patient did not consent to surgery, so we test the patient. In angiography, we can see the large tumor has typical feature ACC. But beside that, there is a special thing here is there are a very small, tiny nodule in the segment 6 that has typical feature of ACC, and the special thing here is this nodule is not completely not appear on MRI. Even the MRI with previous and in the video replace there nothing. So here is the coronary construction of the arterial phase in CTA, and we can easily find all the feeders from the large tumor with the main feeders from the segment 5 artery, and there are 3 more feeder artery. It is the second, the third, and the fourth. And finally, there are the small feeders for the small nodule in the 5 segment. So we can make a plan, and we select if the feeder in others and do not waste time for the non-feeder arteries. This is the first, the second, the third, the fourth, and the fifth. And then we treat the patient with his vascular alone and the visit. And here is the imposition on this tumor. This is a small tumor after the test. And then how about the extrahepatic feeder? Of course, we cannot see the extrahepatic feeder in the CTHA, but we can predict their existence. In the seventh case, we have a 50-year-old male patient with high level of AFP and a large ACC mass on the second stick. On angiography during test, we confirm that there are only 1 lesion and no lesion in the CTAP and CTHA. In the CTHA, we can see a defect of the lesion enhancement, so it suggests that there must be an extrahepatic source of feeder artery. In this case, the patient will decide to have a surgery after, then we do not try. So we do not try to select the extrahepatic feeders, and in the CT after test, we show that there are residual tumor in the tumor, and it corresponds with the defect already in CT. Okay. And this stone is profused by a branch from the right infraphrenic artery. The patient was operated after 2 weeks after test. And finally, the last advantage is the lip or FCT can monitor the embolized zone and critical response. The recent research has shown that imaging biomarker that can predict the efficacy based on simplicity, and among us, the complete repeatable deposition on angiosity is an important predictive factor. In our last study, we had a 59-year-old male patient with hepatitis B and high level anti-P. He has two SCC in segment 5 and segment 8. And the SCC and the feeder was detected on angiosity, and we performed the selective test. They were completed the deposition on lip test, on lip CT, and this is a tumor after test. And this is a smaller tumor, and in follow-up we can see the tumor is complete response, shrinkage, and the anti-K level is decreased. So, in conclusion, I want to emphasize that firstly, angiosity provides a good quality and high contrast image, which are extremely useful for test procedures. Angiosity can detect and diagnose SCC accurately and easily, so the suitable strategies can be made. I want to emphasize again the easily was because sometimes, in many times, the lesion is still can be visible on CT or MRI but it's not easy to see them. And because maybe sometimes it's very difficult to see all the lesions, so we can miss it and make the wrong decision. Thirdly, angiosity can exactly identify the features, and lastly, angiosity can predict the efficacy of just arterial chemo embolism.
Thank you for